Hi, my name is Pravin Dugel. I'd like to give you a talk regarding THR-149 for the treatment of diabetic macular edema. I'd like to present to you the results of a phase 1 open-label dose escalation study. There's no doubt whatsoever that we've made great advances in the treatment of diabetic macular edema, and I think there's no doubt whatsoever that we still have a great deal of unmet needs. For instance, as good as anti-VEGF treatments are, and they indeed are the first line of treatment, we also know that a great deal of patients, probably up to 40% of patients, are not adequately treated and don't respond the way we would like them to with anti-VEGF treatment alone. It also makes intuitive sense in this complex disease that there are other pathways that are involved. As important as anti-VEGFs are, as important as the suppression of anti-VEGF-A is, clearly there are other mechanisms of actions that are involved in the treatment of this disease. And I'd like to present to you today a new mechanism of action. While why target plasma kallikrein? We know that plasma kallikrein, or PKI, is a VEGF-independent mechanism. It acts independent of VEGF upregulation. We know that the PKal kinin system is upregulated in patients with diabetes. We also know that in preclinical studies of diabetes, PKal mediates vascular hyperpermeability, leukostasis, inflammation, and microhemorrhages. And these may be things that are not as efficiently done with VEGF-A suppression alone. We know that there's also evidence for clinical efficacy for PKal inhibition with hereditary angioedema and DME. So targeting plasma kallikrein in DME appears to make sense. THR-149 is a potent, reversible peptide inhibitor of plasma kallikrein, or PKal. The rationale for targeting PKal in DME is that it's independent of VEGF-A suppression. There are patients who have been profiled that appear to have a high PKal level that may not have a high anti-VEGF or VEGF level. So this appears to be an independent mechanism of action. That's why it appears to be an attractive mechanism of action to suppress as a complement to suppressing VEGF as well. I'd like to present to you a study regarding THR-149 that was a 3+3 dose escalation study that had 3 different doses. What I'd like to present to you is the entirety of the study, which was read out at month 3. These were patients who had diabetic macular edema that had a central subfield thickness of greater than 320 microns and a visual acuity between 62 and 23 letters, and had a history of response to prior anti-VEGF or corticosteroid treatment. The baseline characteristics of these patients were well balanced. The safety overview was excellent, and there was really no significant DLTs whatsoever that was seen. Adverse events seen in the study included adverse events that were related to the injection itself, and there was no concern about adverse events related to the drug. And here are the results. Very importantly, with a single injection, these patients who were previously treated, there was an immediate improvement of visual acuity that was maintained throughout the study. Remember that it was a single injection, and there was an immediate rise in vision that continued to progress throughout the study up to month 3. The OCT behaved somewhat differently. The OCT really didn't show much of a change, and this may be related to a different mechanism of action. It's important to remember that the OCT is a measure of permeability and may specifically be a measure for VEGF-A suppression and not necessarily this mechanism of action. So here are the key takeaway messages. THR-149 is safe and well tolerated. There were no dose-limiting toxicities. There were no ocular SAEs. One treatment-related AE was seen, and this was considered to be due to the injection procedure itself. The second takeaway message is that the mean best-corrected visual acuity was fast with a single injection in this previously treated patient population and it was maintained until the end of the study. At day 1, there was a 3.9 letter increase. The maximum increase occurred at day 14, which was 7.5 letters. And at the end of the study, at month 3, there was an improvement of 6.4 letters of vision. It's important to realize that in this early phase study, there are 2 things that we look for. One is safety, and the other is a biological signal. And I believe both were met. The safety profile was excellent, and there was clearly a biological signal in these advanced patients with a single injection. It's exciting for me to think that we finally have something that may add and complement VEGF-A suppression as an additional mechanism of action.